Good afternoon. Welcome to today's presentation, Health Equity in a Changing Behavioral Health Landscape. This webinar is part of a series hosted by St. Clair County Community Mental Health during the month of September, which is National Recovery Month. Today's session is being recorded and will be uploaded to the CMH YouTube channel for future reference. Please feel free to use the chat box to ask questions and comments you have at any time during this webinar. And if time allows, we'll answer as many questions as we can at the conclusion of this presentation. Our presenter today is Erin Williams. Erin is a senior advisor at the National Council for Behavioral Wellbeing and has more than 17 years of experience in the field of behavioral health services with an emphasis on substance use treatment and prevention, workforce development, and the implementation of evidence-based practices in clinical settings. Over this time, Mr. Williams has written and contributed to numerous articles and reports on drugs of abuse, primary care and substance use integration, mental health and primary care integration, workforce development of behavioral health providers, and the implementation of medications for addiction treatment in clinical settings. And with that, I will turn it over to you, Erin.
All right. Thank you, everyone. And thank you all for inviting me today, for what I think is a really important topic, during Recovery Month when we, celebrate, recovery for people who are able to move forward from challenges related to mental health and substance use. Certainly, this is I think a critical month for us to engage and do reflecting about what can we do as a community, as a country, to continue to promote recovery, to continue to provide resources and services to people who may be struggling with a substance use disorder, and to continue to help our country move forward as we want to better address substance use as a part of healthcare. So, one of the things I wanted to do today for the next, hour or so, with your questions and mixed into this, is talk a little bit about where we are now in terms of substance use and substance use disorders in this country. Then talk some more about, where we're headed, what the landscape currently looks like from the standpoint of health equity, and then talk about potential solutions to really address some of the inequities that exist within our system of service delivery. So with that being said, I think most of you can kind of see my screen. Again, if you have questions, at any point in time, please feel free to add those into the chat. I'll be able to answer those. At the end, we'll have some more direct time for Q&A. So what I want to do here is, just start by going to our learning objectives here, where I really want us to kind of understand sort of what the current state of SUD is in the US. We want to talk a little bit more about, what health equity is, what are health disparities, in the context of substance use and mental health services. And then we want to discuss really solutions to address disparities in mental health and substance use services, across the country. I would ask that our moderator here, if she would do me the favor of just a little bit of a time check in the chat when we get to about 45 minutes or 10 minutes of the hour. That way we can, if we haven't already gotten to Q&A, we can get to Q&A at that point. But again, feel free to put some questions in the chat. If something comes up and I see it, I can try to answer it during the course of our discussion. If not, we'll try to cover those, at the end of the session. So, all right, so why don't we jump in here? All right, and so I've done a number of these slides over the last few I guess, months or so. And, many of them, I usually start with this slide, this picture. Part of the reason why I start with this is because I think, it's really important to note and to provide some context for what we're going to talk about. Over the last close to half, 3 years now, I think we have, seen a number of things that are really unprecedented. I think that many of us who are of a certain age have seen a number of, different things happening in the world, 9/11, other things. But I don't think any of us really could have foreseen or predicted a global pandemic, that would have, led to essentially, much of the world being shut down for a period of time. The kind of, immediate sort of morbidity and mortality that was caused by the pandemic, and sort of general harm to our systems, across the country. Mixed in with that, we also saw sort of a reckoning in some ways around sort of social justice, really arising out of the murder of George Floyd in some ways, really, I think, a sea change in how many people across the country, think about concepts of social justice around health equity, racism, and an engagement around these topics that I think hasn't really been seen, at least not in recent memory. You have to go back maybe a few generations to really see, that sort of a movement. With that being said, and that sort of mix and constellation of events, we have sort of this idea of, mental health, within the country, the individuals in the country's mental health. And to be quite clear, there is really nothing as it relates to mental health and substance use that, the pandemic and all of the things that sort of occurred over the last 2.5 years didn't make worse, to be quite frank. And you'll see with some of the numbers exactly what I mean. But we are really in a very unprecedented time, particularly as it relates to mental health and substance use. And we really need to think about, strategies and solutions to better address mental health and substance use challenges among our population, to really deal with the sort of trauma and other stressors that really lead to essentially some poor outcomes. So here, I want to just talk a little bit about this, because I think this is something that, is on the minds of many of us within the context of the field. This number is from the CDC, and it is through, I believe, December of last year. And that is 108,000 people died from a drug overdose. That is the most, within a 12-month period since they've been keeping track or recording the number. The vast majority of that is related to some sort of a opioid overdose. Much of that is around, synthetic opioids now, such as fentanyl. But if you ever look at any of this data, you would see sort of a dip in our, overdose sort of deaths around 2018, then the beginning of a rise in 2019, and then of course, through the pandemic, significant rises in the rate of, drug-related overdose. As many people are aware, fentanyl, which is a very powerful synthetic opioid, is very much a part of the drug supply now. And it is really increasing the risk of overdose death for many populations. We've seen a change in the sort of the demographics. So, looking at the 2000s and up through about 2015, 2016, significant amounts of deaths related to drug overdoses and opioid overdoses within rural context. A lot of it due to the overprescribing of pain medication. But now you're seeing a shift. into urban areas, and more people of color, particularly males, are dying of drug-related overdoses, specifically opioid-related overdoses, because of the mix of fentanyl and some other opioids into synthetic opioids into the drug supply. So we really have a much more significant problem than we had even years ago when we knew we had sort of an epidemic at that point. So we definitely need more strategies, and how do we think through, better ways to address this, really ramp up our use of evidence-based practices and other early intervention tools to begin to address this. Even within that, we also have sort of simultaneously, in some ways, still significant concerns around alcohol and alcohol-related deaths. Again, this is data I think from was reported. It's from the CDC, but it was reported through JAMA, and you see an increase in alcohol-related deaths from 2019 to 2020 of about 25%. Moving that number up to about 99,000. So almost 100,000 people are dying of alcohol-related deaths, in addition to the overdose-related deaths. So again, significant morbidity and mortality, related to substance use, currently. I think I saw some data the other day. I believe 2020 and 2021, both years, I believe we had more than 3 million total deaths in the U.S., which is the first time that the U.S. has ever topped 3 million deaths since they have been recording, those records. So again, significant amounts of that mortality, is actually related to behavioral health causes, particularly when you throw in other related drug use deaths and suicide. So significant amounts of that morbidity and mortality related to that, even in the midst of COVID. So here, this is just general data from the National Survey of Drug Use and Health, which is the chief way in which America gets its sort of national data around substance use and substance use disorders. So we have roughly from 2020, about 40 million people with some sort of a substance use disorder. The larger context of that is about 28 million with an alcohol use disorder, and another 18 million or so with some sort of illicit drug use disorder. And a lot of that is actually related to marijuana, but again, significant use of prescription pain relievers, methamphetamine, cocaine, as well as other stimulants and heroin use as well. So when we think about drug-related overdose deaths, as I sort of talked to you about earlier, it's not just looking at the opiates. When we think about drug-related overdose deaths, we're also now, talking about methamphetamine, stimulants, and other drugs as well. So here you see a significant rise in deaths related to methamphetamines. And then you see here, this chart really talks about deaths between the ages of 25 to 54 and has it broken down by ethnicity. So as you see all of these trend lines through 2018, they're all headed upwards. So in each of the sort of ethnic groups within the United States, you see the beginnings of significant uptick in drug overdose deaths involving methamphetamine. In some cases, that is because of the increasing dilution or infiltration of fentanyl into the stimulant drug supply. But you also see some deaths directly related to methamphetamine and other stimulant use without opioids as well. So what else is sort of happening over the last 2 to 3 years? We're also seeing, an increase in demand for mental health services. Also, we're seeing sort of significant, strains on our behavioral health workforce, as many of you may be experiencing. I've been around the field for quite some time now, close to about 20 plus years or so. And certainly, particularly the substance use field, there was always some level of churn in terms of staffing. People, quitting or leaving positions or retiring and aging out of the field. But even now, I think most experts think of what's happening now in terms of people leaving the field and some of the workforce challenges being some of the worst that they've ever seen. We're in the midst of kind of, I guess, sort of a restructuring, at a community and sort of country level of where and how people work. And certainly that has led to, I think, an increase in people leaving positions, looking for, that sort of balance, work-life balance. And certainly, again, lots of sort of workforce-related shortages, particularly for mental health and substance use providers, as a part of what's happening. All right, so I want to just kind of pause here a little bit, just to see if there are any questions or comments related to any of that data. If you have a question or comment related to that data, please feel free to kind of pop it into the chat. I can try to answer it there. But I also wanted to just take that time to both pause and then, level set as we begin to talk about and do sort of a deeper dive into this idea of health disparities and sort of what's happening in terms of health disparities related to some of the substance use data that I have, already gone over. But before I jump into that, I do think it's appropriate for us to begin to have a conversation about the actual terms, what we mean and what terms you'll hear me talk about here in the next, set of, sort of conversations. So certainly, again, if you have any questions or thoughts about any of the numbers I presented, feel free to pop that into the chat. But otherwise, I'll move forward here with a bit of level setting around what we mean and what we're talking about as we begin to jump into this idea of health disparities. So one of the things we wanted to talk about in terms of these kind of terms and definitions is the idea of discrimination. And there, what we're really talking about is unjust or prejudicial treatment of different categories of people or things, especially on the grounds of race, age, or sex. We think about something like prejudice. We're talking about preconceived opinions that are not based on reason or actual experience. You also hear people talk about and using, this language, within sort of the larger conversation around health equity now, oppression. And we're talking about the unjust treatment or abuse carried out by leadership as a means to maintain power. Certainly, we talk about the concept of racism. I think it's important, again, to have these kinds of definitions to help level set. And racism really involves one group having the power to carry out systematic discrimination through the institutional policies and practices of the society, and by shaping cultural beliefs and values that support, these racist policies and practices. So you see this idea of, one group having power and actually the power to, carry out discriminating programs and processes, and also having the power to also shape the cultural beliefs and values in ways that, support the racism, but also support maintaining, the status quo in terms of the power dynamic as well. You also hear people talk about this idea of systematic oppression. And, we're talking there much more about practices, laws, and customs within a society, that are upheld by both, police as instruments of government, and sort of the society at large. And they're meant to keep certain social categories in power while unjustly restricting other groups based on some particular difference. So again, you see this idea of systematic oppression. It talks about really the structure, the programs and policies, that are carried out, again, that restrict, one group and empowers another. Again, I think is a really, good concept to around, as we go into sort of the next phase of this conversation. So let's talk a little bit about health inequities. This is from the National Academies of Science, Engineering, and Medicine. I think it's a good example of what we mean when we're talking about health inequities and structural inequities. But from a definitional point, health inequities arise when certain populations are made vulnerable to illness or disease, often through the inequitable distribution of protections and supports. So again, think about that idea. Health inequities, we're really talking about the unequal distribution, protections and supports. I'd say the sort of unfair and unequal distribution of protections and supports. And so when we think about this idea of, let's say, health disparity, right? So we're talking about, really thinking about them being connected to sort of people's social context. So disparities in health outcomes, that are considered unfair or unjust, and maybe connected to other factors, such as, some individual factors, but socioeconomic factors, political factors. When we think also about them in the context, social policy has contributed to these sort of health disparities. Again, we're talking about these sort of differential outcomes between groups. You also have to think about other sort of factors, housing, what neighborhood people live in, access to work, educational opportunities, some lifestyle concerns, socioeconomic status, and also access to healthcare and also access to high quality healthcare. So when we think about health disparities, among particular racial ethnic groups, there are a multitude of issues that need to be addressed in order to really begin to close that gap in terms of the disparity. It's not merely a healthcare access issue. It's not merely an education issue. In many cases, it's a broad subset of societal community concerns that have an impact on the overall outcome of services and care and people in general. When we think about in healthcare, again, just to kind of clarify, differences in the incidence of mortality and burden of disease and other adverse health conditions that exist among special populations in the group. And these differences, are not just unnecessary and avoidable. They're often, and in most cases, considered unfair and unjust. Again, it's not merely just the difference between races or ethnicities or genders about a particular, health metric. It's that these differences, seem avoidable. These differences, seem unnecessary, and in lots of ways, they seem unfair. So when we talk about health inequities in the context of, say, racism, we need to really understand what it means. to talk through racism. And you think about racism as a system of structuring opportunities and assigning value, based on phenotype, and that value based on phenotype typically unfairly disadvantages certain communities and individuals, unfairly advantages other communities, also undermines the realization of full potential of the whole society through the waste of human resources. I tend to think this is a really important part of the conversation about racism. Actually, as a part of some of the work that we've been doing at National Council, we happen to have been reading the book by Heather McGhee called The Sum of Us. And, she talks very candidly, I think, about how racism really hurts everybody, the whole of society, the whole of the sector that's experiencing, racism, not merely, the people who are the targets of the racism, but everybody. And again, thinking about that idea, this undermines the realization of full potential for the whole society. And I think we can have that conversation around healthcare, and healthcare in particular, because you see some of these inequities and other things end up hurting all of us in the long run as it relates to what our healthcare could be, what our healthcare outcomes could be. And when we think about this work, it's important that we think about it within the context of this, because again, it's not merely providing services that benefit persons of color or people who may be disadvantaged. It is also about helping the broader society. So when we think about some of the current landscape, particularly as it relates to health disparities and health inequities, National Institute of Mental Health says that members of racial ethnic minority groups in the U.S. are less likely to have access to mental health services, less likely to use mental health services, more likely to use inpatient hospitalizations and emergency rooms, and much more likely to receive lower quality care. And that statement has a significant level of importance because, the utilization of hospitalization, hospitals, and emergency rooms is just by sort of definition within our healthcare landscape, the most expensive form of care. So, the more frequently we have people accessing those services as opposed to, some of the community services that might be available that are, pushed forward, we are sort of adding cost to the overall delivery of services, and I think that has an effect on our bottom line as well as sort of the level of efficiency and our ability to provide services for more people. When we think about psychiatry, it's shown that racial minorities are less likely to achieve symptom remission and are more likely to be chronically impaired given a mental health diagnosis. Racism and bias have been identified as key contributing factors to inequities. Slavery and racism, as well as current realities of oppression and violence, has uniquely impacted the mental health of African Americans have higher rates of severe depression, yet lower rates of treatment. We are less likely to receive office-based counseling for psychological stressors and more likely to be seen in the emergency room. Again, as what I was saying earlier, we have a disproportionate diagnosis of schizophrenia, and also we're the most likely to be treated with antipsychotic medications. They have lots of lasting and sort of potentially negative side effects if not managed particularly well. When we think about overdose related deaths, as I talked about earlier in our conversation. Part of that, you also see a real changing landscape as it relates to race and ethnicity. Here, again, this is data from the CDC. I believe this is through 2020. And you see the change between 2015 and 2020 in terms of the drug overdose rates. Black men, their drug overdose rates more than tripled in that 5 years. But you also see significant upticks in Hispanic, Hawaiian Native, drug overdoses, Alaska Natives, and even some uptick, pretty steadily among Asia Pacific Islanders. You also see some changes in substance use for women, women of color. So again, you begin to see, what's happening in terms of the rates of overdose deaths are beginning to creep up in communities of color. So how do we think about shifting our priorities in ways that help to address that? You look at healthcare coverage. Healthcare coverage, by race and ethnicity. And you see, again, significantly more coverage in terms of the private insurance market for whites, than other populations, except for Asians. So again, healthcare coverage has a significant impact on how and where you go get care. In some ways, may dictate the quality of care that people receive. So really, it's a huge factor in whether or not people are able to get better, find a recovery, or improve their overall health. Here, this is really talking about some of the inequities across treatment access. As we think about, again, that opioid overdose crisis and buprenorphine being one of the 3 FDA-approved medications for opioid use disorder. So we want to get that medication out to as many people who need it as possible. But we see over time significant inequities in our ability to get that medication to the people who need it. Black patients were 70% more likely to receive a prescription for buprenorphine at their visit when controlling for payment. Was 70% less likely, to receive a prescription for buprenorphine at their visit, even when controlling. Study really shows that buprenorphine treatment is concentrated among white persons and those with private insurance or self-pay. There's some interesting sort of corollary data that talks about this as well, where particularly in rural communities, you have significant lack of access, particularly for Black Americans, to buprenorphine, but also a lack of access to methadone as a medication that some may need as well. And this has real implications. Part of the reason it does is because, buprenorphine is an office-based medication, meaning you can take it at home or you take it in your regular office, clinic, visit, health center, and the like. The fact that you're able to do that versus methadone, where you have to go to a opioid treatment provider or methadone clinic and take the dose there. And you have to do that every day generally. That can be a significant, but have significant implications on the types of work, the types of employment that a person can have, and also still have time to go receive the medications. And it really can have an impact overall on the lifestyle that people live, being sort of tied to a treatment program. Now, some of that is changing a little bit, legislation. Some things were temporarily changed during COVID to allow for take-home methadone, larger doses of take-home. People looking at distributing methadone in lock boxes around in particular neighborhoods and communities, so people don't have to travel, to the clinic. to get methadone. So there are some things that are changing, but as of right now, we still have these significant kinds of gaps, particularly across race and their ability to access these life-saving medications. Here, this is talks about simply about how people are treated after an overdose. So this is a study of privately insured people who had an overdose and they were treated in the emergency room. And that data found that referral rates were low. In particular, minorities were less likely to receive follow-up care after overdose. So part of this conversation is not just about how do we identify people earlier, how do we intervene in more appropriate ways, but also even after people receive some kind of care, what does that look like? Like, how do we even engage in follow-up care for people who are using substances? Because again, we know that recovery is a process, so this goes a very long way to really helping people on the road to recovery. Here again, just to go a little bit more into this idea of racial disparities, again, across sort of different racial divides, when we think about women looking with opioid use disorder, Black, non-Hispanic, and Hispanic women were significantly less likely to receive any medications for treatment, and were less likely to use medications for treatment during pregnancy. Again, you understand sort of the implications of pregnancy, but both buprenorphine and I think methadone, there are protocols to help address opioid use disorder within pregnant populations. And we want to make sure that those resources and that knowledge base is being distributed to everyone across the country. We think about other sorts of pieces of this, where we look at some disparities there related to Alaskan Natives, and also thinking about a 2019 study that demonstrates that buprenorphine treatment is concentrated among white persons and those with private insurance or self-pay. So again, how do we make these medications, life-saving medications, more accessible to people going forward? Here, certainly this extends to our conversation around jails and prisons. It's very difficult for us to not be able to talk about this as we talk about healthcare, since so much of our healthcare for many individuals is actually done behind the walls in prison. And this data is really looking 2015, I believe, so it's a little bit older, but it is looking at the sales of drugs, and also looking at criminal justice data by race. So Blacks are about 6.5 times more likely, or as likely as whites, to be incarcerated for a drug-related crime. So when we think about drug use being similar between whites and Blacks, we have a significant difference in who is actually incarcerated for drug-related crimes. And again, that has a considerable impact long-term, particularly when you think about what some of the implications are of being arrested or even convicted. In some places, felonies, you lose your right to vote for a period of time, if not, permanently revoked. So again, these sorts of disparities have real-world consequences for all of us in some ways. All right. So again, before I dive into this next section here, we'll talk about, some of the issues and concerns related to trauma and other things that people need to be thinking about as they think about working with clients from different multicultural and ethnic backgrounds. I did want to stop to see if people had any questions for the chat about any of the key sorts of resources or comments about any of the material that's been presented so far. Just wanted to make sure that everyone was okay with it, and that if they had any questions at this point, then I can go ahead and answer some of those. Again, feel free to drop that in the chat box, and we can try to answer that as well. In the interim, I'll talk a little bit here about this idea of cultural and historical trauma. So thinking about things like genocide, slavery, pandemics, massacres, systematic discrimination, forced relocation. These are all traumatic events. These are all very traumatic events, that can impact and shape people's mental health, that can impact and shape people's substance use. So we want to, as we think about working with clients in this population, we want to really be cognizant of these things. We want to be able to ask about these things. We want to be able to, converse and talk about these things. These are, generational traumas in some cases, that can impact, not just minority populations, but really, all populations in some way, in many different ways. So it's important that we have a skill set and a knowledge in some of these areas that we can bring to the table to help address, some of these, issues. I think we saw a question in the chat box about, what are your thoughts on working on minority counselors, working, with, I guess, minority clients? It sounds like that's what we're talking about there. I have some thoughts about it. I'll share, much of that a little bit later in this presentation, but generally, I think, people, want to have, staff and service providers that are, reflective of them in some way. I think that is something that is an idea that is shared by a number of people from marginalized communities. And so certainly that is something that could go a long way in helping to build trust and engagement in services, within a broader context. But what I'll also say about it, it's not merely enough to just have clinicians of color or clinicians from marginalized communities working with patients from marginalized communities. There also are skills, and those skills are not exclusive to people of color or people from marginalized populations. They're skills that everybody can learn, that everybody should be engaging in within the context of providing services. And those skills are really the things that we value and can help create the therapeutic bond necessary for people to get better, no matter what the race or ethnicity is of the provider or the client. So I think there are some, so I'm very supportive of this idea, but also I'm keenly aware that this is about the skills to do this kind of work. So when we think about this idea of social determinants, which again is a big factor, particularly in the rationale for why people use drugs or use substances. Again, we have to have, an ability to work on these things, to address some of these things. You see now numbers of different, public health officials, health centers, substance use health programs, hospitals have all sort of seen the connection between social determinants and outcomes around health. So they're looking at ways that they can begin to work on these issues and concerns, and try to address them in some significant way. So when we think about social determinants, we're talking about things like economic stability. What is your physical environment? What is your education level? What food do you have access to? Are you engaged socially within communities? Are you part of community boards or some other thing? and in the actual healthcare system, right? Who is your provider? What was the coverage? How culturally competent they were? What procedures did they do? So those things are all contributing factors to health and health outcomes. So we have to think very broadly about that. How do you help people move into recovery? How do you help people become full and activated members of society? A lot of that has to do with these social determinants, not just a provision of a particular service. So here again, we talk about social determinants, things like conditions of birth, is there housing available? What kinds of environmental exposures are present? Are there other issues happening? Again, drug use being cheap. What is the stress level? How economically secure people are, and then what do they think about the opportunities that are available to them from a political perspective. Here, this is a rubric that is done by Shem and Compton. They are some of the foremost psychiatrists in the field. I think Dr. Shem has actually redone this particular graph and updated it a little bit, but this idea of social determinants of mental health. And so when you think about this idea of poor mental health or disease or morbidity, where does that come from? Maybe that comes from sort of genetic risk and other things, or there could be some brain injury or some other thing going on. But you also see this idea of environmental factors having a role, looking at sort of high-risk behaviors and stress, but also food insecurity, housing, early childhood resources, the general distribution of opportunities, public policy, social norms. So this idea of, essentially racism and discrimination having an impact on the distribution of resources, on housing, on education, and these other things. And what Shem and Compton are sort of putting forward is that has a direct relationship to mental health and the mental health status of individuals. So here again, as you think about doing some of this work, this is a slide that I kind of always throw in there, which has a number of different screening tools for social determinants of health. The Prepare is used a lot by health centers, and it is a good way to kind of figure out, if someone has, sort of the capacity to really, provide services or move into long-term recovery. And this really helps you assess that, those social determinants and really get them to places that might be more helpful. It also will help you shape as an organization what kinds of meetings within the community that you go to. Are you at sort of clinical meetings? Are you going more to meetings that are related to larger sorts of community concerns, like putting in a public park, or addressing an issue around landfills, or addressing some other issue. Those do speak directly to these social determinants, and they do have an impact over time on health. So here, this is this sort of some barriers. This is by the National Alliance for Mental Illness. It talked about some of these barriers, for care, for African American, for so ethnic minority racial groups, lack of availability in terms of service providers, times of hours of operation. You also have transportation as an issue, childcare. In some communities, they don't believe that treatment works at all. So that kind of education and mythology, high levels of stigma within minority populations. You have mental health system weighted heavily towards minority value norms, racism, bias, and discrimination in treatment settings. You see different sort of resources provided to people of color versus people versus others based on nothing more than sort of race. Lack of adequate health insurance coverage is still a big issue as a part of this work as well. All right, so we have a little bit of time here, so why don't we talk a little bit about solutions before we jump into some other questions. Again, if you have questions, please feel free to throw those into the chat and we can talk about those. So here, I think when we think about the healthcare system and sort of the changing landscape, I think this gives you an idea of, maybe we're headed or people may be interested in headed. So we talk about this idea of equality, sameness. Everybody gets the same resource. Well, that may or may not solve the problem for particular people, particular people from marginalized populations. You then move into this idea of equity, where people sort of get what they need when they need it in order to, mediate the problem, and people get sort of the services they need. But then there's this further concept, is the idea of justice. And the idea of justice really is talking about the idea of let's remove the barrier that impeded everybody in the first place. So rather than give people sort of quick fixes, rather than give us people sort of the same thing or different things, we want to just focus on or think about steps that will help us remove the that prevented people from living whole and holistic and happy lives to begin with. All right, here, one of the things we want to think about, again, back to that question I believe that someone asked earlier, is this idea of, cultural competence, or even, what I would say is cultural humility at this point. So really thinking about sort of what are the levels of this, going from cultural destructiveness, culturally incapable, to cultural blindness, to actual pre-contemplation, or pre-competence, cultural competence, and then cultural proficiency. And I think that, again, that idea has changed, this idea of cultural humility, right? So you're able to move in ways that allow you to listen to and hear people from various cultures and backgrounds, and be able to provide what they need when they need in the way that they need it. We also want to think about this idea of cultural adaptation. So how do we take some of the evidence-based practices and some of the educational materials and make them more culturally relevant? Looking at, is this topic relevant? What are some of the interventions that we need to use to address it? How do we, stage or create the intervention program? What kinds of elements are most important for a particular population? So how do you go about asking those questions to understand what that is? And also really paying attention to what particular populations are, where people are on particular issues. Has their opinion evolved, or the opinion of the community evolved over time to something different? And do you need to explore that? Again, so, thinking about this idea of recognizing trauma as a huge factor in mental health and substance use challenges, recognizing that impact, identifying signs and symptoms, fully integrating trauma-informed approaches into your policies and procedures can have a significant effect in making sure that people have the kinds of resources and get the sort of treatment that they need that will allow them to come back. Again, thinking about other things that people can do, you want to begin to develop, sort of an organizational broad broad organizational approach. And back to the idea of what meetings are you going to within the community? How do you think about case management and the resources you need much more broadly? Have real dialogue between patients and providers to, so that they understand treatment decisions and next steps. You want to engage the entire staff. So staff at all levels must be engaged in this idea of cultural humility and even linguistic competence in some ways. So making sure that you have interpreters if you need them and other things to move forward, that has to be a part of the entire staff's issue or entire staff's role, not just a particular subset of people. So the admin staff and others as well. Also, again, you want to think about issues around translation, making sure that you have forms that are that can be easily translated or within the languages of people who you're trying to or know you're engaging in treatment. Think about community and community-based evidence-based practices. Looking at hiring people who represent the local community, providing language support, particularly around mental health literacy, making sure that people are competent and understand what mental health and mental health challenges are and what that means, and sort of dispelling any myths and rumors, and also developing broad plans to engage people. Not just within the pandemic, but even beyond that. I think a lot of things have changed. We need to be really responding to that, particularly for people who have already been marginalized in the workplace. All right, so I'm going to stop here. We have a few minutes left. So I'll show you some of these resources, and then I can just actually come off of sharing my screen and just see if people have other questions or comments for the last few minutes. Here, just some resources and some scales. So if you want to begin to start doing this work and looking at things that may be happening within your particular communities or particular organization, you can use some of these tools that might be helpful to begin starting that dialogue. All right,
All right, so if anyone has a final question they'd like to throw in the chat, feel free to do so. I have one that I'd like to pitch to you. I think most, if not many, many, if not most of us on this Zoom today work for behavioral health organizations. For employees that might be looking to create some grassroots change within their organization, you had a lot of like organizational strategies for employees that might be wanting to kick off some of that work themselves. What are some strategies to get that started within our own organizations?
So I think one of the things you can do within organizations, if you want to start with like small groups, you might want to focus on a particular idea, because I think there are several sort of levels to work at this, right? So part of being able to engage in a more equitable way externally is to make sure that you're engaging in an equitable way internally, right? So thinking about what may be happening within your organization in terms of hiring, in terms of promotions and other things, right? So looking at practicing that kind of work internally through creating employee resource groups, or thinking about looking at reviews to make sure that you are paying particularly people of color who may be working there appropriate salaries, and you're not there aren't any sort of issues around equity there, or even women especially within the context of that workforce. So thinking about those kinds of things, I think can be helpful in preparing you to do some of that external work. The other thing I would say to connect to that is, the idea of, putting together a small group of people to begin to kind of think about these issues, right? And maybe you have some people who are passionate about it and who can be champions of that in a short period of time. So thinking about maybe empowering that group to begin to have some discussions. What could we do? What is going on in the context of the organization in terms of, equitable services for people? Giving them access to some data so they can look at that and see, are people of color having difficulty with transportation, or are they coming from further away, making it less likely for them to make appointments? Are there things that we can do? Do we need to advocate to the organization to go after funding to get an ACT team so you can better serve people out in the community and go to you go into communities as opposed to having everybody try to sort of get to you? Our telehealth service is a way to even these things up. Those are some of the questions you want to consider. You also want to consider these clinical sorts of issues, right? Are people getting the same treatment and services? Are you coming in with one diagnosis and others the same diagnosis? And are you guys really getting, similar or optimal care? Are there discrepancies in what's prescribed for one group versus another? You want to explore why that is. So there are lots of things you can do, I think, internally, but you want to empower some people who are passionate about it and maybe allow them to explore a few things and give them sort of a time limit and access to some stuff too.
Yeah, thank you. Thank you for that. There's some sage advice in there. All right, so I just want to thank you, Aaron, for your time and all of your fantastic information today. I want to remind folks that the PowerPoint that was presented today is already on our website, the same place that you registered. So that information is there. There's some great graphics that I know folks can look back at and use that information within our organizations. So just to recap, today's presentation is one of many webinars scheduled throughout the month of September. You can still register for any of those upcoming presentations at stccmh.org. Thanks again for joining us today, and we look forward to seeing you at our next webinar.
Yep, thank you. And that's my email address there. So if people have questions or comments, you feel free to send me an email. And thank you all. It was a pleasure speaking with you all today. Thank you.
Thank you so much.